In the words of Bob Dylan, the times they are a-changin', and there are few things that have evolved as far as the healthcare world has evolved. Changing times in medicine, tonight on Call with the Prairie Doc. Good evening, and welcome to On Call with the Prairie Doc. We're recording our show tonight at the wonderful South Dakota Public Broadcasting Studio in Rapid City. It really is a great facility. In the 1600s, English life expectancy was only about 35 years, largely because infant and child mortality remained high. Life expectancy was under 25 years in the early colony of Virginia, and in 17th century New England, about 40% died before reaching adulthood. Today, life expectancy in the U.S. is 78 years, with the leading cause of death of heart disease. In Canada, people can expect to live just over 82 years on average. There have been many changes in the state of health over the years, and those changes are still coming. First, let's take a look at this week's Prairie Doc quiz question. True or false? In one study of people living in a long-term care facility, they found a 66% reduction of falls when the benzodiazepine sleeping medicines like Ativan or Ambien prescribed for anxiety or sleep were reduced or stopped. True or false? We'll have the answer later on in the show. Well, joining us tonight are Doctors Joy Falkenberg of Regional Health Medical Clinic in Custer and Dr. Jolene Falkenberg of Medical Director Niobrara Community Hospital, Lusk, Wyoming. Did I say that?
Niobrara. Yeah, that's good. Everyone struggles with it.
Yes. And there are two sisters, medical doctors, who've been working out here, West River, rural South Dakota, practicing medicine in two different communities. And you've been buddies growing up. One is older than the other, but that won't be brought up at this point, will it?
No. Yeah. One is older, but one may be wiser.
Yeah, I see. That's how that goes.
Right.
And I've heard rumor that you are championing pig wrestlers.
Hog wrestlers.
Oh, hog wrestlers. Now, what's the story about hog wrestling?
Well, there's a weight difference. That's why she clarifies the hog thing. It's a much harder process to lift a hog rather than a pig. But
oh, really?
Yeah, they're big.
I didn't know this.
Right. We, of course, grew up in rural western South Dakota on a ranch, and so at our local county fair, they always had competitive hog wrestling, which was a very competitive thing. So we did that all through our childhood and even way into our adulthood after having children.
Our other sister Jody is still the ringer, and she still is on the team, and
she still won this fair.
They still
is that
won
right?
This year, yes.
So, I mean, do they grease the pig or the hog?
It's just a mud.
It's a mud bath.
Yeah. Mm-hmm.
Oh, gee.
Yeah, it's good, and it's good for you. I'm sure that the mud is good for you. Yeah,
it relates. So, I mean, you take mud baths and makes your skin.
That's right.
If it hadn't been fermented in the beer pit from the night before, it might make a difference. But yeah, it's an interesting hobby. So, we're multi-talented.
Yes.
Yeah.
So what interested the two of you in healthcare, and what got you into medical school?
I think you would say the same thing. We actually went and visited our older sister, Joanne, who's a physician in California, but we visited her while she was at East Tennessee State University. And she had phenomenally interesting people there. We went down for maybe a week, and that was probably the first thing that we were interested in.
When you were in high school?
When we were in high school, yeah.
And
she worked in rural Tennessee with a very rural population, and it probably propelled us toward family medicine.
Yeah.
Is she a family physician?
Mm-hmm. Correct.
And then Dad was a professor for college, but we did all kinds of things on the ranch, and he could do cesarean sections and everything, genetics, AIing. So that was
a lot of science exposure.
Yes.
AIing, what is that?
Artificially inseminating the cattle.
Oh, yeah. I was thinking aortic insufficiency.
Oh, right.
Yeah.
So both of you are family physicians. So what is a family physician? What is family medicine? I mean, that's an interesting story. I have my own comments because it really just happened prior to my getting to med school.
But I was going to make a little joke because Rick's, of course,
Pretty
internal
old.
medicine. Yeah, right. So it's internal medicine, except for we were able to also do OB and pediatrics.
Yes, you're a little broad. Right. So you do internal medicine and peds and OBGYN.
Well, we like to believe that we could take care of any patient that walks through the door. That's our goal, of course, no matter the age or health status but that's what we enjoy about family medicine, whether it be a newborn or actually we thrive in helping people through their death process too. We want to take care of an entire family and be part of that family unit and feel like they were comforted because we were a part of their lives, and that's really what encompasses family medicine, whether it's the birth of your child that you're celebrating, the loss of a loved one, or complications in between of health issues of diabetes or cancer or otherwise. We are supposed to be the person who helps man your health care and send you to others if necessary.
A lot of people say that's primary care. Would you call it primary care?
I would call it one of the branches of primary care. You know, I would say it's one of the branches, but the thing that makes it a little bit different is that you really are caring not only for a family unit, but generations of families. So where both of us work, we not only take care of baby, but we take care of grandmother and daughter and son. And so when there's one thing that happens in the ER, and we're in the ER, or our partner is, we also know how it impacts the whole rest of the family.
And maybe even the community.
And the whole community, yeah.
So that's an interesting thing. When I started practicing in Brookings, South Dakota, after teaching for 3 years, which was, I would say, one great experience, but the experience of working in Brookings has been fabulous. But I was the ER doctor when I was on call. I was a hospitalist all the time, and then I did outpatient medicine. Now the evolution has been that there's an ER doc or a care provider there. There's a hospitalist, and then there are outpatient doctors.
Right.
And that allows people a better lifestyle. The physicians can, have families with a little bit easier lifestyle for them. But there's been some losses. What's your comment on that, Jolene?
Well, I don't participate in that system as much as why I enjoy it. So it's a necessary evil for a large system such as Rapid City Regional here. It's very hard for a primary care physician to schedule an entire clinic and then all of a sudden realize they have to be up at night with an admission and go see that person in the morning to see how their pneumonia has resolved. But being in a small community like I am, my community's 1,500 people, I am typically the clinic physician, but if my patient's in the ER and I know them well, and I have a different ER doctor other than myself covering, I'll go down and explain the patient and see the patient. And the same is true, even though I may not be the daily rounding physician, I help to integrate their care, which gives continuity. Some people don't admit some of their social history problems, whether it be strife with a loved one or an alcohol issue or things that can really play a role in their health care. And so if I know the patient well, I think that I can offer them better care in the long run.
Right. That continuity is really the important word.
Patients are really vulnerable when they're in the hospital, right? They're scared and they sometimes don't communicate as well as they would have, and there are things that they don't want to just disclose to a stranger sometimes. So it's helpful when we come into a room and we know.
They go, she already knows.
Exactly, yeah.
I don't have to talk about the fact that I've had loss in my life, and I've been depressed in the past, or I've had trouble here, or this is this.
Well, especially just knowing some realm of the community. I have a very predominant agricultural community with a high deductible insurance plan, and if they came into the ER with a chest pain or an injury, it's probably bad. It's probably serious. They don't intend to present to that hospital unless it's a necessary evil.
Yep.
So
they usually don't come in, do they?
Right.
Well, we're talking about changes in healthcare. There's a lot of changes been going on, but some things haven't changed. Let's talk a little bit about that. I mean, are there core values that haven't nudged, or where would you go with that, Joy?
I would say that the core value of just like you and I were talking about how much we love healthcare and how much we love patient relationships. I hope that for everybody else that hasn't changed. It certainly hasn't changed for me. I know it hadn't changed for you.
Changed.
I love being very intimate with my patients in a way that I can talk to them and understand them and feel their pain and really go beyond just writing them scripts. Understand their whole self and their whole being so that I can help them try to navigate their health care and transforming into something better,
That walking in their moccasins.
Right, yeah, absolutely, yeah. So I don't think that has changed, and I hope that it never changes for the younger generation.
There's some things that have interrupted that communication, and actually it's a tool that should have enhanced our ability to communicate and to understand things. It's called the electronic medical record. Jolene, do you have tell us what you really think.
Yeah, we all have electronic medical records now. We're required to as a mandate through primarily the Centers of Medicaid, Medicare. And in some ways, I think that it is helpful. I can find historical prescriptions and some of those things. It's just a different way of interpreting the information. So when you're trained the way that Joy and I were, it's a whole different way to look at it, and you have to retrain your brain. But unfortunately for me, I get very behind on my charts because all I do with the computer in the room is to look through the patient's medications, allergies, or some historical medical literature, like when was their last stent for their coronary issue placed, or different medical history. Otherwise, I try to put the computer aside and actually talk to the patient, or you can miss some really important details, or maybe not even a detail that was spoken, but a facial expression that, you know, I have seen doctors, unfortunately, nowadays who are looking down at their computer and their patient has started to cry and they didn't even realize it. I mean, you need to be involved in that experience, and the computer interferes with that.
I've heard recorded that 20% of the time the doctor's with the patient, and 80% of the time she or he is with the computer.
Right, it seems like
that would be atrocious, wouldn't it? Yeah.
Isn't that an awful thing?
Yeah.
My sense is that whoever is leading this could do better.
Right.
Yeah.
And I think what's happening is, instead of making it simpler and more of an aid, it is a frustrating hindrance, and there should be something done about it.
There should be something done.
I'm angry about it.
You know, I'm convinced that what's going to happen is, what's going to be done about it is the market's going to drive it, meaning that healthcare systems have bought up physicians, and physicians are primarily employed. And what's going to happen is that physicians are going to demand this, and they're going to work for corporations that actually have people that help them with this type of work.
Well, something's happening with your practice.
Yeah, we're doing a new model that we're very excited about, where my nurse and my MA will become CTSs, and they'll do an
MA and CTS, I don't know what those are.
So, you know, unfortunately, I can't get all the. I can't remember either, but it's a technician basically.
Yes.
And they'll do an expanded rooming role where they come in and they talk to the patient about their initial complaints, and they gather the data and they put it into the computer. And then while I'm speaking to the patient, they will be putting in what I'm saying behind me. Yeah, right. So like if we were talking about, oh, you had this coronary stent, that was in May of 2018, you know, before then, May of 2018, coronary stent. And by the time you're done with the visit, you know, and you've just been speaking to the patient, behind you, they're doing your brain work. Our sister in California actually does something very similar with Google Glass, where they're actually from a distance doing it, and they're documenting the visits from a distance.
Right.
But then at the wrap up, they're able to give them their recommendations. They're able to give them appointments, and the whole time they've actually felt the presence of me
being there, looking at them, watching their tears.
The harder part about that model is it'll be successful for Joy because she has staff that has been very consistent and reliable, that the patient population is really comfortable with. That's going to be a whole additional person in the room other than your physician. So the Google Glass issue, even though there is someone back there, or an electronic or internet model that's helping you to record the visit, it doesn't feel as intrusive maybe.
Right.
I have been fortunate enough to have very consistent staff considering the small town I'm in, but that's how that has become intrusive to my life, is EMRs, staff, all those things cost additional dollars. And when you're running a very small facility, that gets really costly. And I mean, even for regional, I think it's been very costly with their transition to Epic.
Right.
That it cuts into productivity, and that cuts into revenue, and that affects everyone.
Epic is a brand of electronic medical record.
Yeah.
Which is another thing. I mean, there was a free electronic medical record through the VA that was plenty good, that anybody could have for free, and yet we all had a compulsion to go to a horribly expensive thing.
It ends up being about the money on the other side of this, right? I mean, there are people who have a lot of money to make on this, so there's no way that somebody was just going to say, oh, let's just go with this one EMR nationally, even though we just went from a problem on paper to a problem on electronics. You know, I think people think they're all interconnected. They're not all interconnected. If you're on Epic, you're on Epic. If you're on Athena, you're on Athena, and they don't talk to each other, folks.
Well, in our community, finally, they're putting the electronic medical record that is in the clinic in the hospital so that they can talk. And actually, they were the same system for years, but they still wouldn't talk.
Right.
You know, it drives me crazy. You know, you would think, I can remember going to the hardware store and I'd buy 3 bolts and nuts and a screw and a pair of pliers. And when I went through, he went doot, 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 and he automatically was going to replace those pieces. And the computer was perfect for him. Right. It is a lost opportunity. But we should probably not talk much more about this because I'm frustrated. I will tell you this, that I think it will evolve into a much better system and we will be able to communicate wherever we are with the computer systems.
It will be forced to.
And it has to be.
We have said before, you know, like they encourage us that, oh, maybe you just can't change. Oh, no, we can change really rapidly. The frustrating thing is actually this is not changing rapidly enough for me.
No,
it's not
changing.
Yeah, rapidly changed.
No. I think if the people screamed loud enough, the people out there said, we demand an electronic medical record that is not destroying our communication from our doctors, then we could get something better done.
Sure.
Let's talk about other issues of ethics. You know, we talked about compassion. That's one thing. One way I like to summarize ethics in care, in healthcare, is beneficence, which is do good, and non-malfeasance or non-maleficence, which is don't do harm. That's one ethic. I kind of summarize that: be kind. The second one is veracity, which is truth-telling. But it's also searching for the truth. I mean, scientific scrutiny, because there's all this misinformation that isn't proven, that we should base what we do on science. And the third one is autonomy, that we respect a person's choice as much as they can. Those are 3. I mean, there's justice, and then there's, you know, there's a variety of different things. But when I'm interacting with a patient one-on-one, those be kind, be honest, respect people's choices kind of carries me through. So I thought I'd throw that at both of you. Jolene, I mean, is that, where are you in an ethical world of expectations?
I'm still very fortunate to care for a population that respects my opinion. They come to me for it. For example, our sister in California takes care of a community that probably has a lot of expectations when they already come to her, considering their
that's right. You've got the
background.
California reflection, don't you?
So I think that I'm fortunate that way, and probably that's why they sometimes come back from their own oncologist who's a specialist after talking about their cancer diagnosis and come to me and say, well, what do you think? Because we've developed a relationship, and that's what's so important about primary care. As an example, a lot of the problems I see nowadays probably revolve more around cardiology. Why are 86-year-old people getting bypasses or coronary stents so that we can keep them healthy long enough that they are crippled or frail or debilitated enough they have to go to a nursing home? We have to understand a point when we don't intervene all the time.
And I would say the same thing about like maleficence and beneficence. When you talk about something, you could do a device in anybody. The question is like, how's that going to look totally? How's it going to look when they go through the hospitalization, the post-hospitalization? If they're just barely teetering at staying at home, and I mean just barely, and they may end up in the nursing home, have that conversation with them. You know, so I've seen them talk about a frailty score, you know. What's the frailty score look like on a preoperative visit? You know, because if it's high, maybe we should really back away from that. You know, or how many times are we actually really talking to people about what their autonomy is? You know, would you want to be in the ICU? Would you want to be put into the nursing home? Would you want to be put on a ventilator?
Do you want to be put on a feeding tube?
Yeah,
Do you understand the repercussions of that? Because I think a lot of people, if we say it in a simple statement, of course they say, well, I would want to do everything. It seems, you know, especially coming from an area of very conservative values, it seems wrong to not do everything, somewhat immoral or something. We're like, no, medicine can do everything forever. It is endless as long as medicine can keep you alive. So the likelihood is if you're over age 70 and you go on a ventilator, you're not coming out of it in the same way that you went in, and we need to be honest with our patients about that some events aren't reversible.
There's a time that no matter what we do, they're going to die. But if we do intervene, we're going to drag them through suffering.
Right. And costs.
And costs. But I put costs aside.
Yeah.
Suffering is the issue. And
just humanity.
We're all going to die one day.
Well, I was interested to see recently with Mr. McCain that we heard, whether he said this or somebody else said it, that like he was no longer doing medical treatment. I don't think that's probably true. Mr. McCain was probably no longer doing oncological treatment. But there's a range of medical treatment, listening skills, treatment with pain medications, nausea treatment, palliative care. There's a whole range of what we do besides just putting devices in people, prescribing medications, that is all medical care. I hope people see it that way.
I hope they realize that we do more than just drag them through suffering.
Yeah.
I mean, sometimes we hold their hand as they die, and that's okay.
And that's doing something too.
We're talking about ethics. Let's do this. Sometimes a change in methods or technology bring up a question of ethics. Just because you can do something doesn't mean you should.
The function of a mentor is to serve as a kind of exemplar, kind of a model of appropriate behavior. I would have to say my primary heroine, of course, is my wife, Dee Granholm, and I also look upon my 3 sons, their wives and their grandchildren as models or perhaps heroes of mine as well. When I used to do research at the University of Minnesota, I worked with a clinician there, and he was a superb molecular biologist as well as an excellent physician. He taught me a whole series of techniques on how to conduct biological assays on variables important to pigment cell biology, which were important to concepts of melanomas, what causes melanomas, and how they can be treated and cured. One day I went to see this clinician and arrived at his office, and I went into his office and I found him crying. And I said, "What is the problem?" And he said, "I've had this patient now for 30 years and she died." So now there was an example of a mentor that not only was superb in the laboratory, but also an excellent physician and a caring human being. One of my other mentors, Dr. Joseph Pellegrino at Georgetown University, told us once, when you're in the operating room, you have to make a decision. You don't have time to have these long, protracted ethical debates about what's right. So one has to appreciate both the theory as well as the practice. Well, let's take a look at General Petraeus, for example. Up until his recent indiscretion, he was very much of an excellent model, looked upon by all military personnel and many others as, one might say, an epitome of what it is to be a general, a military person, a warrior. During the course of his activity with his interviewer, he made a moral lapse. On the news this morning it said his moorings came loose. Now, we as the public have to consider whether or not we would be willing to forgive him for his moral lapse. Now, the question is, how many of us are perfect human beings? How many of us make mistakes? Perhaps not as egregious as that mistake, but perhaps even more egregious in some instances. And so we all have to look upon ourselves as considering the possibility of forgiving people for what they've done and giving them another chance. Physicians do have perhaps a greater responsibility than the average citizen to conduct themselves in ways which are appropriate not only to their profession, but to their own personal moral compass and to what they think is the appropriate way for people to behave and to be moral actors in their occupation and in their lives. Another thing that I find particularly intriguing is for those people who have virtually no social stability as children growing up, yet somehow they become hugely successful and they become willing to donate a lot of their resources to help other people. And invariably, somewhere along the line, they have a mentor. They have a teacher, a clergyman, a friend, an adult of some kind who takes them under their wing and just provides a little bit of stability. It doesn't take a whole lot, but it requires a little bit. And those people who come from nothing and are hugely successful and donate to the world are my real heroes.
I really love a discussion about ethics. To me, that's really the core thing that doesn't change, and it's important to me. There is one of the things that's really changed in my practice was when the computer came out and people started Googling their illnesses, and they would come in with the diagnosis. What are you going to do for my sinusitis, you know, for example? What's your take on that, Joy, about people using the computer?
I think it can be a really good thing because it can keep them engaged and it can allow them to sort through some things. But if they sort through things before they come in and they only give me half the picture, I'm going to be sent down a rabbit hole that is not a good. So they have to give me all the information. And then I would also say just being aware of a physician's time. You know, I think that we're all working under an intense amount of pressure, especially like in the ER. And sometimes you'll go in and explain something and somebody will get on their phone and they'll want like a med school lecture about it. And the reality is like we don't have enough time to go into like what a monocyte is. So if the doctor says like, this is good, this is, you know, there's no signs of an infection, this is what's going on, there is going to have to be a level of trusting, not in big things. If you ask big questions, people need to answer them. But if you take every minute detail and dissect it down, it's going to frustrate your doctor a lot.
I used to have an elderly gentleman who I loved dearly, but he would come in with a long list. He was a kind of a slow, meticulous engineering kind of a guy. And he would start with number 1, and then I would answer that, and then it would be number 2, and then I'd answer that, and then it would be 3 and 4 and 5, and it would go on. And it would eat up an afternoon. All these people had to wait, and so it's hard for me to say sometimes to people, cut, go, I need to move on. What's your take on that, Jolene?
I remember my second year of medical school, we started taking those didactic testing courses prior to our board exams. And you'd have to go into a room and it all seemed very clinical, and this taught me a very good lesson. So it was mostly clinical, like you had to go in and you had to perform a physical exam on a patient. They had to do pap smears. I mean, we went through all these things. And one of the room was a young woman who went on with symptoms, and they seemed to trail on, and finally the instructor would come in the room. And I think out of 50 medical students, all 50 of us failed it because what we were supposed to do is to stop her and interrupt her and get her down a closed path to ask the appropriate questions to get her to a diagnosis. So it is probably one of the hardest things physicians struggle with to help us, help the patient. So the first thing that I try to do if I see people present, especially with a paper list, is to take the list out of their hand, not in a purposeful, mean way, but because then I have an idea of where we're going with the visit. And if it's overwhelming, I say, okay, we're gonna prioritize and let's pick the most important things. But a lot of them usually do
interconnect?
Yeah, they interconnect in some way, and so I can usually help them once I have a hold of the list and can understand things a little better. And I think that most patients nowadays understand the need for physicians, limited time and need to move on to patients. There is still an era of patients who think they would like to go visit with Doc from Gunsmoke and then go to the saloon with them and have the whole day with them, and that's not realistic. But
do it.
So I think if we can be more assertive as physicians in a comforting way in solving problems for patients, that's what we need to do.
And I do appreciate the fact that it's very confusing for patients because it's not information that's out there, right? So you used to have an annual physical, and because it's expensive and because that you didn't utilize the doctor, you saved up your stuff for your annual, Well, that's not really how medicine works now, especially like the Medicare wellness examination is only to discuss wellness. It's not to do prescriptions, it's not to discuss an acute illness. And so if we want to accommodate that, we need to know ahead of time so we have time added on. But I also understand that doctors need to also be aware that maybe that's the only time the person can come in. So if they do schedule that time, do what they need.
Yeah. I like the idea of let's address that one next visit, and let's see you in 3 months.
Right.
And so we can stretch it out and spread it out a little bit, and certainly we'll know how you're doing with this major issue. What is the major issue that's bothering you?
Right.
So you guys are the ones that have the cases. I mean, you have patients that have had interesting cases, and that's always fun for me to hear. What would be an interesting case, Joy, that you've had recently that, or maybe in the past, that spoke to the value of a primary care doctor out in the boonies?
Well, I think one of the cases I had recently that just speaks to what we've been discussing is that I had a gentleman who came in with a UTI.
Urinary tract infection.
Yeah. But when I asked more questions like, well, what makes you think you have a UTI? Well, I have discolored urine, and I'm like, oh, okay. Any other health issues? Well, they were traveling, and no, not really any health issues they thought were important. And I pushed my Care Everywhere tab, and that tab brings up other records if you're interconnected, and this gentleman was through Epic. And I started to say, this is a way more complex case, and the reason that there was blood in the urine is because there were low platelets, and there was a cancer diagnosis and
chemotherapy,
right.
And wow. And so there is a
They're
problem.
trying to make it easier for me.
Yeah.
But I didn't want them to make it easier for me. I just wanted them to give me the details. But then it was an opportunity, right, to teach and say, there are some very important things you always need to communicate. And one thing I think we do a very bad job of is we give a stack of papers out of the ER and very little helpful information, I think. I wish that every single person who left the ER, especially when they're traveling or gets their note. They should get their note from their doctor. Yep. So that they can give it to the next doctor.
Right.
Like, this is what the doctor said.
Here's my problem list.
Yes.
Here's my meds.
Right.
And this is the last note that the doctor, it doesn't have to be 1,000 pages of
Right.
crap from an electronic medical record that's not functioning like it should be.
Right.
It could be communication that's perfect.
Yep. Your doctor doesn't need more Crane's information on hematuria.
Yeah,
They need your note, what was done.
I like the idea of writing a little note to my patients each time. Here is, this
What's
is your
most
problem,
pertinent from this
and
visit?
this is the most important thing, and I want you to remember this. And I did that with my patients many, many times. I had a little double thing so that I'd write it, and then the copy would stay with my paper record, which went away.
Yeah.
And they didn't leave me with something I could write.
Yeah, there's no paper to be found now.
And I want to write, I
Yes.
want to draw. I want to draw.
Yeah, I draw compression
lot.
fractures or something else from patients all the time. Yeah.
What about you, Jolene? We've talked about cases that Joy has. What about a case that you have lately?
Well, as a colleague and a mentor, Rick, you could probably help me with some of my worst neurological cases because I've even sought help from my sisters on those. So.
Yeah.
I have been in Lusk for 4 years now, and Niobrara County is the least populous county and the least populous state in the nation. 2,400 people
In the whole county?
in the whole county. And I have had 4 cases in my 4 years there of myasthenia gravis. And now
No
recently,
kidding.
I said reach out to Mayo Clinic because if they find the cluster, they might find the...
There's cause.
That's right.
We
Yeah.
don't know what. Tell us what myasthenia gravis is.
myasthenia gravis is an odd neurological condition in which the acetylcholinesterase enzyme that functions to help nerves fire,
Yes.
isn't working properly. And so the most common symptoms for classic presentation is what's called ptosis, which is lid leg. But the ones that I have come in crisis with swallowing difficulties and airway compromise and full-on crisis. And one wound up with a tracheostomy even after her stint with it. There's a very specific drug that can manage it, cure it, helps that enzyme work better. But it's a hard diagnosis to come to if you haven't seen it frequently, and so commonly missed unless you're seen by a neurologist. And in my opinion, that's just, there's got to be something in our environment there that I'm not tracking backwards that impacts the neurological system. I've had a lot of young diagnoses of Parkinson's disease. I recently had a patient with bulbar ALS, which is Lou Gehrig's disease, but it's bulbar, so it only affected his tongue. He actually got atrophy of the tongue and swallowing difficulties, and just, I actually have thought about bringing them together as a group because they all know each other and like each other, and they'd be willing to help me if I could track it down together.
ALS meaning Lou Gehrig's disease, which is this progressive
Demyelinating condition, yeah.
where the nerves get weaker and weaker. So that's a tragic story. I mean, I've had a couple cases of ALS, amyotrophic lateral sclerosis, that it's a progressive deterioration that kills.
Right.
And when one of the things that is, I think, primary of importance is that person knows what's going on, what's going to happen, the truth of it,
So that actually brings us back to the ethics dilemma, because when we confirmed that, so I felt all along that was the diagnosis, and one of the neurologists who's well connected with me in Cheyenne, because I've shared some of these interesting cases with her, did some of the testing for it, confirmed it, and then he came back and he said, well, they think that I should consider a PEG tube because he had lost a lot of weight and wasn't functioning well.
PEG tube meaning a feeding tube.
Correct, a feeding tube in his stomach to support his nourishment and calories. And I knew him and I knew his family well, and I said, I don't think that we're allowing you to live the quality of life you want to sustain yourself. He could no longer communicate. His tongue didn't work well enough for him to handle his own saliva or to speak with his family, and it was a frustrating illness for him. And he agreed, and he said, you know, the time may come that I'll change my mind, but I wouldn't want any interventions, and he passed away, fortunately, within a couple months. But
There is an issue about feeding tubes that I think should be addressed right now, and there's probably hardly one more important issue across the board that I think, and that is feeding tubes. Because in many parts of this country, anybody and everybody gets a feeding tube when their future is bleak.
Right.
And all you're going to be doing is keeping them alive in a nursing home. I had a patient who had a severe heart problem. I got the care for them, the surgery for the valve abnormality, and then unfortunately she had a stroke after the surgery was done. So she stroked out. So she was certainly had an advance directive. She didn't want any of this extra stuff. She just wanted a chance of being able to breathe again, and we tried to fix that valve, but it ended up with a stroke. And so she's in the nursing home. The husband called me 6 months later. She's still in the nursing home, doesn't know he's there, vegetative state, in the nursing home in Minnesota. Her home was Brookings.
yeah, very sad, right.
And the husband said, could I bring her home? And I said,
Novel
Why hadn't everyone
concept,
offered that to
why,
you?
why hasn't that been offered? And
Right.
then the other thing is she's got the feeding tube, and she breathes on her own.
Right.
And she's got a feeding tube. Do we really need to continue that?
Well, and I think it's complicated for patients and their loved ones because there's a lot of guilt there. They feel like they're the ones making the life-ending decision when really all we're doing is not sustaining a poor quality of life. And there's a lot of misinformation that people think it is painful to starve to death, to withhold feeding and water and those things.
Say that again. People think that it's painful.
Well, we use the wrong terms. We say do not resuscitate, meaning do not save somehow, right? Instead of allow to die naturally.
Right.
You know?
And allow a natural death,
Right.
A&D.
Right.
I tried to push that at my hospital. They said, no, it's DNR. We're not going to do A&D.
Yeah.
Okay, but the idea of a feeding tube, I think many times is wrong. Now, there's a time for it.
There are times for it.
But majority of time, it's not.
Even treating infections, you know, so if I have this conversation frequently with nursing home families, and I say, let's just imagine that your mom was alive, 3 years ago, and you had a crystal ball, and you sat down with your mom at the farm table or at your table after she just got done gardening, and you said, Mom, I have this crystal ball, and you know what's going to happen to you? You're going to have a stroke, and then you're going to end up not being able to ever go home again, and you're going to end up living in a facility, and you're going to get a pneumonia. Would you want to just die, or would you want me to just do you want me to take you to the ER repeatedly and go back and forth? How many of us would say, like, that's what I want?
Right.
I want to just keep going back and forth to the ER.
Yeah, most
and
of
I
us
want to
would
just
not say that, would we?
No. So think about it not from the standpoint that we all kind of say, like, well, do you want us to do something for your mom or dad? Well, what kind of question is that, you know? Or let's reframe the question. Let's reframe what we're actually talking
The
about,
nature
which
of
is
life
mercy.
is taking its course, right? Humanity.
Being merciful.
Yes.
So I think the idea of an advance directive saying, when I don't know who my family is and I can't take my own nutrition and water, do not put a feeding tube down mine. And I think you can write that and have it notarized and have the lawyer say yes, and it won't work unless your family knows that's it. So I think the thing we need to know about an advance directive is it is a communication tool by which you talk to your family.
That's right. I agree.
Yeah, and I think the electronic medical record has changed that assumption too, because there's this checkbox that's so important that the advance directive has been done, when realistically it's the communication with the family that matters more. I have a lot of patients who will come into my office and say, here's my copy of my advance directive, and where should I have it in case someone needs to look at it? I said, it just matters that your family knows that your next of kin can tell the ambulance driver that we should not start chest compressions,
Right.
you know? I mean, that's what really matters is the discussion.
Have you guys done Comfort One in South Dakota? I don't
We
know
do.
if I'm.
We have Comfort
right.
One.
Wonderful, because it's a bracelet. It goes. They purchase the bracelet, which is nominal. They fill out their wishes, which are do not resuscitate. When the ambulance shows up, their bracelet's on, and they don't start.
That's a good idea.
Resuscitative measures.
Unfortunately, a lot of people don't know what it is. It is not well informed. We have done a show on this, but it was like 5 years ago. I have a dear friend who was a real proponent of this and had Comfort One tattooed on his chest over his heart. Don't resuscitate. So I think the idea of saying comfort only, I mean, the classic case was a man who had severe heart failure. So he couldn't do anything without getting short of breath. He had his mental status. He just totally dysfunctional. And he was not happy. Life was not great. And he said to his wife and all of his family, do not resuscitate. So he has a cardiac arrest.
Right.
And his wife looks at him and she goes,
Freaks out.
I can't.
Right.
Call the ambulance. The ambulance comes in, resuscitates him.
Yep.
And he woke up mad as hell.
I'm sure,
He
yes.
was really mad at her. And it wasn't long later, though, that he had another attack and was gone. But I think that whole idea of making sure that you communicate with your family about what your wishes are.
I agree.
So, dying is not the worst thing in the world.
Well, dying is not the worst
Unfortunately.
thing that can happen to you.
Yes. So the other thing we've talked about is we can talk about is pain, chronic pain. What do you do for someone with chronic pain when you realize that narcotics really aren't as good as they could be or should be or we wish they were?
You know, I have a good network for this, and Jolene's more isolated than me, but I have a wonderful network between chiropractors and acupuncturists and mental health advocates, because part of this is, and I think there are people watching this show that would say, do you have chronic pain? Because you don't know anything about this. Well, you know, maybe I know something about it. There is a transcendence that can occur with pain. We can actually change our brain to see pain differently and to deal with it differently. That doesn't mean you don't treat it at all with medications, but it should be taken care of by a multidisciplinary approach. It should be lots of different things. It should be a combination of musculoskeletal work, psychological work, and anti-inflammatories or nerve tablets, or like there's lots of things to do, but we know opioids actually upregulate the receptors, right? So you can actually deal with less pain over time. Although I'll put my plug in for the fact that I think the younger generation of doctors needs to get familiar with using narcotic pain medications. We are talking about non-cancer, non-palliative care pain. We're not talking about end of life
Chronic
care.
back pain. yes, right.
End of life,
Right.
turn up the narcotics, give it
Right.
if they need it.
Right.
But narcotics work really good if there's a blockage in a smooth muscle tube, a kidney stone, biliary tract blockage. But it's not narcotics are not very good for musculoskeletal pain, not very good for neurologic pain.
Along with the side effects, yeah.
And along with the side effects, why do you think they've added Tylenol to hydrocodone and oxycodone? Because they need a real pain medicine in there.
Right.
Well, one of my most telling times when this happened was our nephew had an accident and he broke his jaw, and he said we could talk about this, and he said, I want that good medication. They keep giving me
That
this
really good one.
Yeah, and that really good one was Toradol, ketorolac, which is an anti-inflammatory.
Like ibuprofen and I think that
Ibuprofen.
those are really very effective pain medicines
Yes.
along with Tylenol. The only thing you got to be careful is they
Got to watch your kidneys.
kidney and stomach, and
Yeah,
it can burn holes in
absolutely.
the stomach. So,
Yeah.
but wonderfully good pain medicine. I like to encourage it, but as an as-needed
Right.
basis. So we could do better with pain medicines, and we could sure do a lot better holding back on the narcotics.
Western doctors are going to have to meet Eastern doctors. I'm convinced of this. I don't know if other doctors are, but I'm telling you, if we would marry the two together,
acupressure.
we would be able to actually do a much better job if we would marry functional medicine and all of that with us.
There's a lot
Powerful.
about my whole practice. I would give local trigger point injection with Novocaine that was very effective in many cases.
Oh,
not
sure.
always, not always.
Well, especially for dental pain, for many reasons. So patients who have real dental pain, the nerve block's going to work better until they can get it taken care of. And for patients who are presenting that don't have dental pain and are using it as an unnecessary excuse, don't really want to have a shot in the gum when it's not necessary. So, but I think that she makes a good point. There's way too many young physicians now that are just saying, well, I'm just not going to prescribe them. No, you should still educate yourself and become familiar about opiates and narcotics and understand when they're appropriate or their side effects, or because they're out there, we really have a big problem with them. So instead of just saying, no, I'm absolutely never going to use these, you have to be educated.
Okay. We've got 1 minute. Any take-home messages the two of you want to say?
Go ahead.
I guess that I mostly just think that we're so fortunate to be in a rural area and practice primary care. I really enjoy it. I really enjoy my patient population. They're so respectful of me. They're so conscientious.
We should encourage young people to go into this world.
Right.
This is a fabulous
We
job.
absolutely have to have them.
Joy?
I'm super lucky to have my partners because that's what makes things work. You know, good doctors attract good doctors, and I think that someday it'll happen for her. It's just a more rural area. And so if we have strong mentors in rural areas and we have support from our administration.
Collaboration, encourage
Right, yeah.
collaboration. We used to do a lot more than we do now.
Yep.
Well, I can't tell you how much I appreciate you guys coming. Thank you
Oh, it's
for
a lot of
being
fun.
on the
Thanks,
show.
Rick.
We love it.
And now for tonight's Prairie Doc quiz question. True or false? In one study of people living in a long-term care facility, they found a 66% reduction of falls when the sleeping pills or the anxiety medicines like Ativan or Ambien were discontinued. True or false? And the answer is?
True.
True.
Yeah.
Those are important things to avoid when you don't need them. And the other options better. We'll be right back after this.
For more than 16 years, the Prairie Doc organization has endeavored to enhance health and diminish suffering by providing useful information based on honest science in a respectful and compassionate manner. Prairie Doc physicians and health professionals continue to answer your questions each week, creating a vast Prairie Doc library of medical information available to you and your family 24 hours a day. Make sure you don't miss a thing. Follow the Prairie Doc on Facebook and YouTube for free and easy access to the entire Prairie Doc library.
The famous American artist Andrew Wyeth graced the world with many works of art. One of his most famous, Christina's World, is at home in the Museum of Modern Art in New York City. This painting portrays a woman in a field of tall grass at the bottom of a hill below a dilapidated farm. On close inspection, it is noted that the woman has rail-thin arms that seem to claw the ground. The woman is Christina Olson, a friend and neighbor of Wyeth in Maine. Christina was an extremely independent woman who suffered from a progressive neuromuscular disorder thought to be Charcot-Marie Tooth disease, or CMT. Her ability to walk as a toddler slowly diminished as she aged. She refused to use a wheelchair or walker, preferring to use her arms for crawling. Charcot-Marie Tooth disease is one of the most common inherited neurologic disorders, affecting approximately 1 in 2,500 people in the United States. The disease is named for the 3 physicians who first identified it in 1886, Jean-Martin Charcot and Pierre Marie in Paris, France, and Howard Henry Tooth in Cambridge, England. CMT comprises a group of disorders that affect peripheral nerves, those that lie outside of the brain and spinal column. CMT is caused by a gene mutation that affects the covering of the nerves. There is no cure, and treatment is aimed at symptomatic care. Upon learning of the story behind the famous and beautiful Andrew Wyeth painting, I enjoy it at a different level. Andrew Wyeth got to know the soul inside the woman who had physical struggles in this life. I'm grateful to him for giving this to the world. I'm also grateful for Dr. Charcot, Marie, Tooth, and all the other scientists who helped and continue to put the puzzle pieces together for those who suffer with neurodegenerative diseases. Their work may not be lauded as masterpieces and displayed in the museums of the world, but their contribution to society should not be overlooked.
A big thank you to our guests and great friends, Jolene and Joy Falkenberg, B-U-R-G.
Yeah, right.
It's always a special evening when they can join us on this program. And thanks to South Dakota Public Broadcasting crew here in Rapid City who have been more than welcoming. We sincerely appreciate your help. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
We are often reminded that too much of a good thing is bad for you. Antibiotics certainly fall into that category. Antibiotic miracles and antibiotic resistance. Next time on Call with the Prairie Doc.
All of us want our family, neighbors, and friends to have the ability to make appropriate decisions about their health care. To do so, they need access to information from reliable sources like Dr. Holm and his guest physicians. Hello, I'm Stephanie Herseth-Sandlin, and I serve on the volunteer board of directors of the Healing Words Foundation, a 501c3 organization established to support the work of the Prairie Docs. With your charitable donation, you can help the foundation continue to offer free and easy access to the entire library of Prairie Doc health education programs. This mission is so very important to rural communities and residents in particular across South Dakota and neighboring states. Please consider a personal or corporate gift. Just go to prairiedoc.org to find more information on how you can help. Thank you.
Major funding for On Call with the Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, American Academy of Family Physicians Foundation and South Dakota Academy of Family Physicians, Avera Heart Hospital, Dakota Allergy and Asthma, CoBank, Fishback Financial Corporation, Vance Thompson Vision, Brown Clinic, Aberdeen District Medical Society, 3rd District Medical Society, 7th District Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Aberdeen Asthma and Allergy, and Swiftel Communications.